Now, the next two charts, again, we're going to have some questions. I know. Questions can be throughout here. I'm trying to highlight a few that I know there's going to be some on. This is what I call traditional PPO alignment. I talked about alignment earlier to make a choice, make a change. All right, on this slide here, this is what I sort of, in a broad sense, obviously, have listed out how the alignment of the different stakeholders works today. You have your employer puts up the plan designs. They're trying to affect the plan member, the consumer, if you will. Your third-party administrator or your insurance company, if you will, is next over there, and they're trying to drive with the programs that they have. And where's the poor provider? They're out there. You may want to do wellness activities that aren't covered. You may want to give information to that patient that the insurance company is conflicting with what they're giving. You may have certain standards of practice, and they're saying, wait, that's not evidence-based medicine. No, you say, yeah, no, I've been doing it for 30 years. It's really effective. So you have all these conflicts on these these black arrows in all these different areas, potentially. I don't think that's a very good model, but that's what we've had. The focus is on behavioral change of the members, but it's coming from the insurance companies who really aren't being insurers at that point, are they? They're just being administrators. They're not taking any risk. But here's where I think that we need to move, and where I think we're starting to move in some ways. I call this the integrated delivery system model, and in some ways it's what the accountable care organization structure in the ACA has been promoting. I don't know that it'll turn out effectively. I got my own opinions. We'll talk about ACO's accountable care organizations later on. But here's the better approach to me, that you actually, consumerism at its core, we've already talked about several core issues, but one of them is that it ought to improve the patient-provider relationship. There are too darn many people interfering with the patient-provider relationship. They get their own rules and guidelines, what you can say, what you can't say, what you can deliver, what you can't. This is the model which I think is the most effective approach, to get the providers and the employers working together on what is the best way to deliver medicine and what services are allowed under the plan. I mean, if you think about the relationship between the insurance companies, who again are just acting as third-party administrators, and the providers, what kind of relationship is that anyway? It's adversarial to begin with. What's the first thing they do? Well, cut your rates. They want to negotiate down. Yeah. Right. So the insurance company doesn't own the patients. They don't own the members. They like to make you think that they do because they've got a network. They don't. The employer can actually more directly contract with many of the providers out there, and I don't know why providers haven't done more direct contracting. Say, listen, I'll take care of all your diabetics next year for X dollars. I'll take care of all your mental health patients for X dollars. Because, you know, there are a lot of things. How do providers get reimbursed? They get these codes, CPT codes, ICD-9, now ICD-10, and you got to identify that to get paid. Well, let's take, you talked about mental health earlier when we went around different areas of interest. What if you got a mental health patient and they're really having, social problems? They can't be functional on the job, or their kids can't be functional, and so the worker can't be worrying about their kids. The kids can't even go out and feel comfortable in a crowd. They can't go out and rent an apartment. They can't go out and shop for themselves because they have these phobias. Well, what if somebody said, wait a second, why don't we take them to a Braves baseball game where they have to deal with a crowd, and we'll actually, that's not a CPT code. Nobody gets paid for that. So you're structured under the reimbursement process, and guess who owns the CPT codes? No, not the insurance companies. The AMA. It's proprietary to the AMA. They own it. And if you want it, it's not public information. You got to buy it. You have to buy it from them. That's where they make their money. So there's an adversarial relationship between the insurers and the providers that just starts from day one. And then they tell them how they can practice medicine. They get too many people in there who are non-MDs telling people how to practice medicine. So the model of consumerism really should focus on how do I improve the patient-provider relationship. Now, as an employer trying to put together programs, there are some thoughts and ideas we can talk about how to do that. This is still pretty new. I introduced this just last year to the conference and said this is the next phase, is what I see developing in healthcare consumerism, is a real focus on patient-provider relationships.